Caribbean Surgery Inc. welcome you to Health for Life, the first ever medical show on television that deals with prevalent health problems and concerns in an easy-to-listen to question and answer format. To find out what we are discussing today and to introduce us to the visiting specialist, here is the producer and host of Health for Life, Dr. Surendra Prasad.
Good afternoon. My name is Dr. Surendra Prasad, and welcome to another episode of Health for Life. Health for Life is a program designed to inform the public about common medical conditions. Today, we will be discussing asthma in children. My guest physician is Dr. Rohan Jabour. Dr. Jabour is the most experienced pediatrician in Guyana. Dr. Jabour, thanks for joining us on today's program. So now, Dr. Jabour, we've summarized what asthma is. Now let's get into the treatment of this condition. How does one treat asthma?
Okay. Asthma, in terms of management, we divide it into two sections, basically. Like most diseases, you have what is called the acute attack, which is what is happening right now. Something has gone on, whatever is the stimulus, it's triggered off the reaction. And the child or adult is having an acute reaction, which means the reaction is occurring now. The tubes are tightening, the airway is getting narrow, oxygen is not getting to the blood and to the body as it needs to. The second part of it is now after they've gone through that stage and you've got the acute attack, you've now got to manage it because it's not going to just go away simply. Okay. The medications do not work instantly. They work. And some of them will work temporarily, and it's usually short-lasting. And then you're going to get the chronic type, which is going on now for days, and that you've got to manage. And that's where a lot of treatment falls down. Especially in children now, we have to consider certain things in the management. The drugs that we use are basically of two types. Because if you remember the diagram that I showed you with the muscle wall, and then this mucosa lining, we have medications whose job is to relax that muscle. Okay. And once it relaxes the muscle, the airway is open. That type of medication usually acts very, very quickly. However, it doesn't only act quickly, it also wears off very quickly. So the person who's been treated with these acute management bronchodilators, as we call them, will get temporary relief and feel okay for a little while. But if you don't continue that treatment with the bronchodilator, it soon contracts again. Okay. Because usually the underlying cause is still there. Whatever is the allergen or the virus or whatever it is that's triggered it off. Now, while that is going on, the medication we will use is these bronchodilators that you'll give intermittently over a period of time. Some of them every 2 hours, some of them every 3, every 4 hours, depending on how severe the attack is. The second part that then develops is the swelling that I'm talking about. And this swelling is the only thing that reduces that swelling and thereby stops the mucus and cold from forming inside of the tubes are what we call steroids. Okay. Now, everybody knows that steroids are dangerous drugs. Okay? In children, particularly so, it is dangerous. That because they're growing, their hormones are developing, the overall child's metabolism is faster. He's utilizing these medications faster. And so medications like steroids are quite dangerous on a long-term basis. We have to use them. If we don't use these steroids, the child is going to die, or the person is going to die. Okay? So we have no alternative but to use it. In the past, the major medications that we're using in terms of steroids, things like prednisolone, which everybody knows, and now today we're using dexamethasone. But this type of medication, when you just use it generally, the long-term effects are terrible if the person has to be on it for a long period of time. And so within the recent years, and by recent I mean in the last decade, 15 years, we've managed now to produce what we call the inhaled steroids. And what happens is that we now can give the steroid in what we call a metered dose inhaler. I demonstrate some of this just now. And these metered dose inhalers will allow you to put the drug directly into the lung and into the lung tissues. And so the drug then can act directly. What the advantage that you have then is that you can use minute dosages. Okay, so you don't get all the what we call systemic effects, which means effects all over the body.
Okay.
And so you can then put children on these medications for a period of time to get full control of their lungs again. And that revolutionized how we manage asthma today. And so when we talk about with children now, we have a special problem with that. In order to get the inhaled steroids into them, and this is a mistake that I've seen constantly be made, is that doctors will go and give the parents these medications in the form of inhalers. And I'll just show you what an inhaler looks like. This is an example of 2 inhalers, okay? Two different types of inhalers. And this, when you when you actuate it, as we call it, and there's a spray that comes out, I'm still pressing it. I haven't released it. Now I'm going to release it. What came out there is a dose.
Okay.
So a dose there is equivalent to if you're giving the child a dose of an antibiotic and you say 1 teaspoonful. That is a dose.
Okay.
You've got to give a teaspoonful. If you give a little bit of a teaspoon, you're not getting the full effect of the medication. The same thing applies to this. When you produce that amount of gas must go into the child's lung.
Okay.
And what I find happening is that the doctors give it to the parents, and the parents would go then and hold the thing and put it in the child's mouth and squeeze it. There's no way that is being effective.
Correct.
And so I'll get a lot of parents that will come to me and say that, they're giving me these inhalers, but they don't work. In fact, if you give me the liquid medication, it works better. Or if you give me the tablet medication, it works better. It's not that it's working better, it's that it's not being used properly. The disadvantage of the liquid, they have these medications also in liquids, or in the case of the steroids in tablets, and liquid as well. But when you give that, you have to give a large dose, because after you drink it or eat it, it goes into the stomach. It then gets absorbed by the stomach into the bloodstream. From the bloodstream, it then goes to the liver. From the liver, it then goes back into the bloodstream, and then it goes to the lung.
Correct.
So you have to give a relatively large quantity in order to get a relatively small effect. And so the medications then, you'll end up with a lot of side effects as well. Okay, so you get more side effects. Whereas if you use this methodology, you use far smaller quantities, it's much more effective, and it's much more being rapidly more effective. In order for children to use these, though, they've now come up with something called spacers, or these are called aero chambers. Okay, this is an example of 2 types of the aero chambers. Okay. They work very simply, and what is involved is that they've got the spacer is a chamber in which you're going to put the medication in. It's got a one-way valve.
Okay.
So when they suck in, the gas goes one way. When they blow, it shuts off,
okay,
and the air comes out. And it's simply inserted into the back of this device. The child, this is for an older one, they'll put their mouth around it, and then you just simply actuate it and tell them pull.
Okay.
And hold it in the lung. And they'll hold it, and it works very effectively. Okay? For smaller children, and these devices can be used even for babies. And this is an example of one where there's a mask instead of the mouthpiece.
Okay.
And this mask, for example, is for an adult. This is an adult one. But you will get the ones now in pediatrics with this smaller mask that even a small baby can use.
Okay.
Okay? And it works the same way. Now, this is a very effective method of administering the drugs. It's comparable to using when you go into the emergency room and the doctors have got to give you a nebulizer with oxygen that takes about 15 minutes to nebulize. And the effectiveness is just as effective. But for a small child or a small baby, it's really a problem, because putting this thing over the nose for 15 minutes creates a great deal of problem for them.
Correct.
Whereas if you've got these type of instruments, which is now available in Guyana, for years we didn't have it, and now you can get them readily without a problem. And they're not too expensive now, they're coming down in price. Huge variation. And so now that we've got those, it allows the parents, when the child is having an acute attack, to utilize this right away. And of course, the children, they get sick in the middle of the night. They don't get sick in the daytime.
Correct.
They're fine in the day, running around playing. At the middle of the night, 1 o'clock, 2 o'clock in the morning, down with their asthma. They're sick. They're unwell. Everybody's in a mess.
Yeah.
Now, with these type of devices, they can get control of it quickly, at least get it to the point where they can go the next morning and see the doctor, and they don't have to run out in the middle of the night.
I think it's important for us to mention the name of this device again, and I assume you can get it in the pharmacies when you buy the inhaler. What's the name of this?
This is called an aero chamber.
An aero chamber.
An aero chamber.
And
there's a huge variation in them right now.
Right. And
That's
they're
available.
vary based upon the age of the child, obviously.
Yep.
Okay, so we have discussed the acute attack, the management of that acute attack, the management of the asthma attack for a few days or weeks afterwards. Now,